Greetings and welcome to this yet another video on inpatient insulin management. This is the example-based video on guidelines-based framework for calculating total daily dose of insulin for individualized patient approaches. This content in this video is provided for exclusively for educational purposes and should not be used as a substitute for professional medical advice. This is Medicine Beyond Harrison. Let's get started. So, firstly, for a lean patient and insulin sensitive patient who is not previously exposed to insulin, and whether they may be a male or female, weight less than 70 kg, HbA1c less than 7.5, the recommended starting total daily dose is zero point 0.2 to zero point 0.3 units per kg per day. This is in order to know that there is low reserve but preserved insulin sensitivity. Example in elderly renal hepatic dysfunction. This is done, and this starting low is done to avoid hypoglycemia. For an average control patient with a moderate insulin requirement, that is mild hyperglycemia with a non-critical illness and on stable diet, if the person is a male for in a weight of 60 to 80 kgs and HbA1c of 7.5 to 8.5, you can start at zero point 0.3 to zero point 0.5 units per kg per day and standard basal bolus starting range. If it is a female of 60 to 75 kgs, HbA1c 7.5 to 8.5, that is in the moderate range of HbA1c, you can start a bit low, up to 0.25 to zero point 0.4 units per kg per day. This slightly lower dose because females generally are more insulin sensitive than males. In poor control or market resistance patient, that means HbA1c of 8.5 to 10 percentage in males and females. Male usually weigh about 70 to 90 kg in this setup of insulin resistance, and females about 65 to 85 kgs. In and also in patients with persistent inpatient hyperglycemia and on patients having infections and steroid, the recommended total daily dose is zero point 0.5 to zero point 0.6 units per kg per day for males and zero point 0.4 to zero point 0.5 units per kg per day for females. In males, need stronger basal and bolus and ensure close CBG titration and adjust if fasting and prostaglandin is more than 180 milligram per deciliter. For a person with very poor control and who is on stress or on steroids in inpatients having acute illnesses on sepsis or steroid-induced hyperglycemia, for a male with HbA1c of 10 to 12, start at zero point 0.6 to zero point 0.8 units per kg per day, often require aggressive basal bolus or titration to IV insulin. For a female with 70 to 90 kg, HbA1c 10 to 12, zero point 0.5 to zero point 0.7 units per kg per day, start high, frequent glucose monitoring is required in females. With severe insulin resistance with HbA1c of more than 12%, you can go up to zero point 0.8 to 1 unit per kg per day, sometimes even more than 1 unit per kg per day. Combine basal bolus or IV insulin. Check infection triggers. For a female, you can start mildly low 0.7 to zero point 0.9 units per kg per day. They often benefit from the basal bolus or temporary IV insulin infusion. This is done in patients who is on long-standing uncontrolled diabetes, infections, obesity, or on steroids. Post-embolization discharge taper with improving HbA1c and stable intake reduced to 70 to 80% of inpatient total daily dose. This is done to prevent hypoglycemia during transition. Also refer to chapter 5 or the fifth video in this series in order to convert the basal bolus in hospital total daily dose to premix or basal plus OHAs at discharge. Interpretation, these five criteria are usually considered for the insulin management in patients. So first and foremost thing is to consider the weight and gender. Secondly, check the HbA1c. Higher the HbA1c, higher the resistance. Third, select total daily dose range 0.3 to 0.8 on which range that the patient falls. Divide it into 50% basal and 50% bolus. Finally, adjust the daily plus or minus 20% based on the trend. So for example calculation, this male with 60 kgs, lean weight, HbA1c of 7.5 with stable oral intake, the recommended total daily dose is 0.4. So the total daily requirement will be 24 units, of which we convert 12 units as basal and 4 plus 4 plus 4 as bolus, 3 times pre-meals. For a female with 65 kgs with average weight HbA1c of 9, which is high, and admitted with infections, and so the recommended total daily dose is 0.5 units per kg per day, which comes to around 32 units, of which we split it into 16 basal and remaining as bolus 5 plus 5 plus 6. For a man who is 90 kgs and heavily built, HbA1c of low 6.9 only, and is on controlled diabetes with just post infection, you can start low with 0.25 units per kg per day. Total daily dose would come around 22. Split it into 50% basal and remaining as bolus, split into 3 times a day. So for a male with 85 kgs with high risk HbA1c of 12.5, which comes under high resistance condition also is having sepsis, you can go up to 0.7 and also even up to 1 units per kg per day. The total daily dose requirement would come around 60 to 85 units per day. Split it into 50% as basal and remaining as bolus 3 times pre-meals. For a female who is 75 kg having HbA1c of 13, which indicates high resistance, and also admitted with poor control of diabetes and no OHAs, so that now the required total daily dose would be 0.8 to 1 units per kg per day. The total daily dose would come around 60, so split it into with a 50% bolus and remaining as bolus. So these are taken from the ADA standards, RSSDI 2023, Endocrine Society guidelines, and RAPID 2 and surgery-based guidelines. So final statement, start low for elderly CKD, hepatic impairment, that is 0.2 to 0.3 units per kg, and then titrate. Verify ways, always verify, not estimated. Errors here can cause large dosing deviations. You can start high for obese patients or on infections or on steroids, 0.6 to zero point 0.8 units per kg early itself. Gender effect modest, but it is relevant. Males tend to need 10 to 15% higher total daily dose for same HbA1c bar weight. The golden rule, adjust daily, 10 to 20% changes based on the last 24